prevention is the best treatment we can do, or early treatment. The second thing we can do is really accept the fact that women need mammograms after the age of 40, men should get their PSA checked after the age of 40, and men and women should start having colonoscopies at the age of 45. So the more cancer screening we can do, the earlier we can treat those patients, and the better their outcomes can be. I agree.
Welcome back to another episode of the Doctors and Dollars podcast. I'm your host, Nate Crannell. In today's world, not only is receiving a cancer diagnosis an extreme shock, but then the patient has to worry about what treatments will be recommended and how it's going to affect their bodies. Today, I'm joined by Dr. Ramji Rajendran, board-certified radiation oncologist and PhD expert in the molecular mechanisms and cell biology of hormone-dependent cancers such as breast cancer and prostate cancer. Working through radiation oncology consultants in the Chicago Metro, he spends his day performing three-dimensional conformal therapy, IMRT, SBRT, and gamma knife radiosurgery. Needless to say, this guy knows his stuff when it comes to cancer treatments. Welcome to the show, Dr. Rajendran.
Thank you so much for having me, Nate. It's a pleasure to be here.
What is going well today?
Well, it's a beautiful day outside in Chicago, and if you don't like the weather, you just need to wait a little while and it'll change. But today we have a lot of sunshine and we're really enjoying a nice summer day.
Well, enjoy it, because just like you said, storms are going to pop up. You'll get the occasional tornado. Who knows? Snow could be coming around. Snow could be coming around the corner. We never know.
Yeah, we just call that a Tuesday.
That's just a Tuesday. Awesome. Well, we're going to talk about a lot of stuff today. You are, as I said in the intro, an expert when it comes to radiation therapy. I have a bunch of questions on you but also you are you're a realist. Is the best way I could say it. There are things that are really important to you outside of medicine, including community, family, your finances. I want to definitely make sure we talk about those things today as well.
Sure. Absolutely.
Cool.
Happy to.
Awesome. Well, I've had oncologists on the show before, most recently Dr. Trifni Troso Sandoval. She explained to me what a cancer cell is and how it comes to be. So today I want to talk to you about the treatments for cancer, both traditional and more new-aged. And so let's start off with the big glaring one. So there's plenty out there on the internet about radiation therapies, the side effects that it can cause on the human body, above and beyond what cancer is already doing to them. So what would you say to some of those criticisms? And then how has technology really changed over the last 30 years when it comes to radiation treatment for cancer?
Sure. So I'd love to talk about both of those topics. I think it's important to understand that cancer treatment today is a team sport. So every patient that's treated, I work in a community hospital setting, but I will assure you most patients throughout the country that are treated are not treated by just one doctor for their cancer. So most of the time, patients are presented in a multidisciplinary tumor board in which they receive information from the radiologist that may diagnose the initial mass in the body, to the pathologist who's able to tell us where the cancer is from and possibly even what stage, and the surgeon, which would then, the surgical oncologist, which would be somebody who's specialized in removing what they can from the cancer, medical oncologists who provide treatment that go through the bloodstream, either with chemotherapy and now immune and biologic therapies, and a radiation oncologist who would be able to provide further local control. So radiation is used in three main ways for cancer patients. The first way is, kind of really cool, is that we're able to take early stage cancers like lung cancers and treat them with curative, definitive intent. So a patient in the past who was not able to receive lung cancer surgery would not have many options at all, but now we're able to deliver, 4 to 5 treatments and curatively treat their lung cancer. The second way in which we're able to help patients is that once a patient has a tumor removed, such as a breast cancer, we're able to provide radiation to the breast to make sure women are able to maintain and keep their breast so they don't have to have a mastectomy. And the third way in which we treat cancer is that we work along with our colleagues to do multimodality care. For example, it used to be that rectal cancer was taken out first surgically, and then the patient may have gotten some chemo and radiation. Now we've totally flipped the script where the patients get chemotherapy first, then chemotherapy with radiation, and then surgery, and that optimizes their outcomes and really allows patients to receive the best care. But it involves a lot of coordination with a lot of different physicians and making sure that the patient is able to, successfully tolerate all of these treatments that we provide them. And so we do similar treatments for head and neck cancer, similar treatments for other malignancies, and we're really able to provide a curative intent. Cancer is no longer a diagnosis that is terminal. It is very much a diagnosis that patients live with and continue to live with that diagnosis. And now I would say cancer survivors far outnumber cancer patients. There are patients diagnosed newly with cancer. So the other way that we treat patients is that we treat them beyond what is typically considered curative. So stage 4 lung cancer is when patients have cancer that's metastasized beyond where the cancer started. And we're able to do things like gamma knife radiosurgery to treat brain metastases. Now, this uses 192 beams of radiation that all point to something about the size of a Skittle or like an M&M.
Mm-hmm.
And we're able to basically get rid of whatever cancer is in that little volume of disease. So when you have small little brain tumors, we can literally pick them out without ever having to really physically touch the patient. So it's, there are ways in which we can treat brain metastases. We're also very effective at treating patients with pain. And the new thing is, as our teammates, as our medical oncologists and our surgical oncologists get better at what they do, we're able to identify patients that have oligometastatic disease, meaning they have just a few metastases, and we're able to treat those areas much like gamma knife in the brain. We're able to apply that to the body and get rid of tumors in the body to keep patients living longer and longer with metastatic disease with an excellent quality of life. So as you can tell, I kind of dig what I do. So
yeah, no, I love it. You definitely tell on your face. You get excited about it, which is what you want when you're going in and talking to a doctor about what's next. So to get excited about it is very cool. How much of it is based on the timing of when a patient comes to you? Because I got to imagine it's great that you guys have the team. 50 years ago, that was probably not the thing. There was probably like one cancer doctor. They kind of did everything. So to have a team of 4 or 5 specialists, that's got to be very comforting for someone who's been diagnosed with cancer. But frustrated is not the word. Is it disheartening to meet a new patient for the first time that's been diagnosed with cancer, knowing that they're already at stage 3 or stage 4, when now some of those treatments are so much more advanced versus, I know early on you can use radiotherapy. If someone's, in the early stages of cancer, you can use radiotherapy. Is it a little disheartening to be like, oh man, you're already this far along, so now we have to use all these specialists?
So I think that it's not necessarily disheartening, but we are getting better about a couple of different things. One is we're getting better at accepting the fact that certain people have genes that are different than other genes, right? We're accepting people with disabilities, with Down syndrome, and in general, having a genetic disorder does not make you, it just makes you need to be appropriately managed in your healthcare. Does that make sense?
Yep.
So patients, I'll use Down syndrome. So patients with Down syndrome have certain cardiac things, so they need to see a cardiologist earlier. They're more risk for certain types of leukemias and lymphomas, so they need to see an oncologist earlier for screening, okay? In a similar way, a patient with a gene that predisposes them to have a breast cancer, a prostate cancer, a GI malignancy, those patients are being seen sooner because we are accepting, which is beautiful, we are accepting patients with the fact that they have genetic syndromes that may make them more predisposed to cancer. So that's about 5 to 10%. And the more we're able to capture those patients early, the better, and the better quality of life, because you're right, prevention is the best treatment we can do, or early treatment. The second thing we can do is really accept the fact that women need mammograms after the age of 40. Men should get their PSA checked after the age of 40, and men and women should start having colonoscopies at the age of 45. So the more cancer screening we can do, the earlier we can treat those patients, and the better their outcomes can be. I agree. But when a patient comes to you with a diagnosis of cancer, I don't look back. I just look forward as to where do we go from here, because it's just not even of concern. We are where we are. So I feel like that's kind of where I start with my patients. And, if a patient has lung cancer and has a history of tobacco use, I don't bring up the fact that they're had a history of tobacco use that may have
Mhm.
increased their risk of lung cancer. That's irrelevant. What we're trying to do is to make sure that we move forward.
Yep. It really is. It's the cards you're dealt. Everyone's dealt cards. You can't go back and ask for a
Right.
reshuffle, right? So,
Right.
yeah, that makes sense.
Exactly.
When is it appropriate to use radiation treatment in conjunction with the surgery or the chemotherapy? You mentioned earlier it kind of used to be backwards as it relates to like rectal cancer. They kind of
Right.
removal and then treatment, and then
Yeah.
that theory is switched now
So
to how often does that happen?
there are now national guidelines as to how each cancer is treated. And so it depends on the type of cancer, it depends on the stage of that cancer, and it also depends on uh, what the latest treatments are and what the latest clinical trials show. So, really, there are comprehensive networks in which we're able to, and societies in each specialty that agree that certain cancers should be treated in certain ways. And the field is constantly moving. I mean, one of the things I really, truly, passionately enjoy about cancer care is that it's always changing. So, there's
Hmm.
always something new. I mean, I'm in Chicago. We get ASCO, which is the National Oncology Meeting, every year. We get multiple other radiology meetings like RSNA, and we get to see the latest and greatest up front, hot off the presses, and we can see those applications in the guidelines and see how patients can really benefit from those treatments.
That's very cool. I might have to come out and visit you at that big
Yeah,
conference.
absolutely. Absolutely. I think it would be a lot of fun. I agree
Yeah,
with you, Nate.
I
But
came.
I
I
think that,
Go
it
ahead.
really depends on the stage and the type of cancer as to the best way to treat them.
Gotcha, makes sense. Yeah, I was actually in Chicago for the double ANS conference, neurosurgery. So, walking around there
Nice.
and seeing all the new, robots and things that they have going on, I thought that was pretty cool. So I'll have to come out to yours. That might be fun.
There's a lot of toys out there, absolutely. And our national meeting is called Astro, ASTRO, and this year it's going to be held in DC, but it has been held in Chicago before. And gosh, the technology there, the application of physics and biology is just really mind blowing.
Isn't that wild? There's always new things in the forefront ahead of us. One of those
Yep,
things
definitely.
I want to ask you about. So, clinical trials, right? Research and clinical trials
Yep,
are being done in every specialty within healthcare. How important are
yep.
clinical trials, not only for oncologists like yourself learning these new technologies, but also for cancer patients who may have, kind of that very unique or rare cancer where it's like, what do we do, doc? Like, how do we do it? And where
Man,
does
you're
clinical
answering
trial
your
come
own question, Nate. You're really good.
in?
So it depends on the rarity of the cancer. So, let's think about the common cancers. So the three most common cancers are breast, prostate, lung, and I'll throw in colon cancer and
Okay.
colorectal cancer there. I would say all of those patients with the majority of most cancers are just fine to be treated close to home, and patients should have as convenient treatment as possible, because clinical trials are not going to be as effective for the first stage or first treatment course of a patient with breast cancer, for example. That's all standardized now, and a clinical trial is not necessarily going to help you. But you said in your question, what about that patient with a rare sarcoma? What about this patient where the doctor says, boy, I've never seen this diffuse pontine glioma before? Well, that is the type of patient that really should go to an academic medical center. And, it is so nice to have great colleagues that I work with within, both University of Chicago and Northwestern and Rush here and Loyola here at the in Chicago. So, you develop relationships with different other physicians at academic medical centers, and you're able to refer those patients appropriately for physicians that have had more experience with treating certain types of cancers, or the ability to enroll in clinical trials. And it really depends again on the rarity of that type of cancer. And there are certain types of cancers that are super aggressive that deserve and warrant the ability to enroll in clinical trials.
And you may not know the statistic off the top of your head, but like how often is someone using a clinical trial as that as that treatment option versus, let me ask it this way, actually. Have they exhausted all other treatment options and now clinical trials is kind of
That's
the Hail
typically the
Mary?
best way to go.
Mm-hmm.
I think that's typically the best way to go. The majority of cancer care is still done at academic, like non-academic medical centers and out in the community. So I think that, I would say 90% of all cancer patients are still treated. I would say almost 95, 99% of all cancer patients are treated by the best standard of care. Enrolling in a clinical trial would involve somebody with a rare diagnosis or somebody that's exhausted all traditional treatments.
Gotcha. That makes sense. Let's. I talked about several treatments in the introduction that I gave for you, so I want to kind of roll through some of those just so that the listener
Yeah,
understands the different options, where specialties lie, and what they can expect if they have some type of diagnosis. So let's start with the early one. This is the one that I know about, not because I had cancer, just I've had people in my life that have had cancer, and this one came up. But radiotherapy. So it
sure.
typically used in the early stages of cancer. Why is it not effective for someone with, say, stage 3 or stage 4 cancer?
So radiation, you can kind of think like a type of surgery in that it's a local treatment.
Mm-hmm.
It works where you put it, but you can cure all cancer if you give patients a high enough dose. The problem is you can't treat the whole body,
Mm-hmm.
and you really have to be aware of normal structures. And we dose really to be safe, as opposed to dosing to as high a dose as possible. So I think that it's a type of local therapy, and it's important to understand that even in that local therapy, stage 3 lung cancer is treated with chemotherapy and radiation, for example. So it really depends on the type of cancer and the stage of cancer as to what treatment is most appropriate. But boy, do we have some really cool toys. So, for example, intensity modulated radiation therapy is a way in which we can use computer programs to tell us how best to treat a certain tumor that may be located near a critical structure and to best avoid that critical structure. So it's almost like each patient gets a computer program that's written specifically for their anatomy to deliver the optimal radiation to their body. Gamma knife radiosurgery, again, is a way in which we can deliver high doses of radiation to very small volumes within the brain, where we're able to treat just the tumor, and literally half a centimeter away from that tumor, there's next to no dose. So it's a great way to treat maybe a pituitary tumor, but still avoid the optic structures and optic nerve and optic chiasm, and really be able to do things that you couldn't do otherwise.
I am super excited to introduce to you the Doctors and Dollars 5-Day Financial Challenge. I'm Mike Neubauer, I'm CEO of Grand Vision Companies, and I'm the one that you see on the Wealth Wednesday and Daily Dollar episodes with Nate. So Nate and I are partnering again to do something even more exciting, which is the 5-Day Challenge. We're taking the best of all of our episodes, all of our expertise and knowledge, and we're condensing it into an impactful and purposeful 5-day presentation, 1 hour per day, for 5 days to give you everything you need to build that foundation for your financial future. So if you're looking to gain the pieces, you want those puzzle pieces and find out how they fit in your financial plan, head over to the Doctors and Dollars website, join us on the 5-day challenge. We're putting it together for free, so you got nothing to lose. We look forward to seeing you on the inside.
In my intro, I mentioned you did IMRT. What about SBRT, stereotactic body radiation
So
therapy?
stereotactic body radiation therapy is a similar way where we can treat to get rid of all the cancer in a specific part of the body by delivering a very high dose to that treatment. To that tumor, we deliver that in early stage lung cancer, for example. So many patients with early stage lung cancer that are not able to receive surgery can be cured with this type of treatment. And there are patients that don't want to have surgery, and even those patients can still be offered a curative treatment based on where their tumor is within the lung and the size of that tumor within the lung and how much it might move.
Got it. That makes sense.
So, it's a way in which we can literally get rid of cancer where it lies. And, it all depends again on the stage and the location of the tumor. But it is something that we can offer our patients that we couldn't offer them, 15 years ago. And so it's a really nice tool to have for the team. Again, it's not just the radiation oncologist. I think any patient that gets any type of treatment needs to have that multidisciplinary agreement between all their physicians so that they agree on what the best treatment would be.
Gotcha. Cyber knife versus gamma knife. Who wins in that proverbial knife fight?
Neither one of them is a knife. They're both different types of radiation. So CyberKnife is really best used for the body, although it can be used for applications within the brain. And Gamma Knife is exquisitely engineered and made for treating the brain, and it really can't go below the brain. So, I think that it's location, location, location. But again, it's not just the technology, it's the physician and the team behind the technology. So I would say they're both winners, and ultimately the patient is the winner because they're getting access to the right technology for them.
That is a solid answer. And as you're talking there, I guess my naiveness kind of came in. And so when I think of radiation, I think of like, they drop the atomic bomb and everyone says radiation's terrible for you and it destroys your body. Earlier, you talked about lasers. And so here's my naive question as a financial guy asking a medical professional.
Yeah,
as they're doing the laser treatment, right? The radiation therapy, you're targeting a very small area. And you mentioned 192 lasers essentially in the size of a Skittle. That is incredible to my brain. I can't even comprehend that.
Yeah.
What does that do to the exterior? What does that do to the skin, the muscle tissue as it's going through to that cancer cell?
It's so little radiation. Each beam is so little radiation that yes, there is radiation has to be safe, and there is so little radiation to everywhere else outside that middle, that volume of the Skittle, that we're able to really focus the beam. But yeah, there is radiation, a small dose of radiation delivered everywhere else, but it is almost 1/200th of the dose. So individually, each beam carries very little effect on normal tissues. So it is the ultimate in sort of focusing the dose. But again, we are very careful with normal tissues. And although radiation can have long-term and short-term side effects that we talk to with our patients, in general, it's very well tolerated, largely because we're very safe in how we deliver that treatment. And we're very careful of thinking about that patient, 20, 30, 40 years down the road to ensure things like long-term risk of heart disease is minimized, things like that. So we really are aware. So you mentioned the atomic bomb yourself, right? Mm-hmm. So I think I'm rapidly approaching the age of 50, but in my generation we were afraid of things like nuclear energy and the atomic bomb and nuclear disasters that we've heard of and things like that. So I think radiation in general gets a bad rap, and it's thought of generally as scary, largely because of the Cold War. But I think that as we understand better the applications of radiation and how we're able to do a better way of delivering that treatment, we also hold that as kind of, we have to bear that cross of, radiation has had bad raps in the past. So we have to make sure that we deliver the best optimal care and really be aware of long-term toxicity. So as radiation oncologists, we kind of carry that, as kind of one of those things where we want to make sure that we provide the best care for the patient and really optimize that benefit versus the risk.
Yeah. Well, I think that's a great answer, just in the sense that it clears the air on that stigma that probably comes, like the word radiation. You're right. I think of the atomic bomb. When I hear laser, I think of like the James Bond movies where that laser's, rolling along the table and everyone's scared that's going to slice their arm off.
And although we use lasers are really ways in which we make sure the patient lines up to the same spot every day. Mm-hmm. We don't really use lasers for treatment. Mm-hmm. There are other doctors that do, but that's not something that we do. We use X-rays, ionizing radiation. Mm. So it's a very specific part of the electromagnetic spectrum. So it's radiation, and it's not something you can see, touch, or feel. It's just energy.
Gotcha. That makes sense. Well, I have the perfect question that segues us, out of the kind of the therapy conversation into you more as a person. We're going to
Yeah,
talk about both all in one question. So, as I was doing some research on you, I found a new word that I didn't know existed: hypofractionated radiation therapy. Uh,
sure.
just saw that
So,
the impact on the bottom line financially for patients is, the way I understand it, it's less sessions because it's more
right,
hyper focused, which
right,
means less cost for the patient. So talk about that type of therapy that seems to be pretty
right.
new.
I would say we are extremely aware that radiation is expensive because of
Mm-hmm.
what we do and the technology that's used. So, as a field, we are very conscious about value. So, we have been able to reduce the number of treatments for breast cancer from approximately 33 to 16 to 20.
Wow.
We have also been able to reduce the curative treatment for prostate cancer from about 45 treatments to 28. So, we are working as we get better and better at delivering the radiation. We also inherently ask, well, could we do this better? Could we make this more effective? Could we, there's time toxicity and financial toxicity that we don't really talk about enough in cancer. But as a field, Astro is very involved in making sure that we provide the best value for patients. And so, we really pride ourselves in being able to provide more dose in less number of treatments, and that's essentially what hypofractionation is. But yeah, there's a financial aspect to that, and so by being good stewards, we are also seeing more patients and being more involved in multidisciplinary care, and we're also looking to new ways to use radiation for treatment. And one of those ways in which we can do that is to use radiation for different benign diseases, and I think that's going to be a real interesting aspect of what we do. It's becoming more clear that radiation can be used for things like osteoarthritis and things like that. So as we're getting better at providing the best uh, utility for what we do, I think we're going to have new indications for what we do. The other hot thing in our field is something called radioimmunotherapy and radiopharmaceuticals, and I think that's going to be very interesting. As we're getting better at targeting cancers with drugs and antibodies, we can then tag a little radiation to that drug or antibody and deliver throughout the body, but really have the radiation go to the tumor and maximally treat that tumor. And just like I just told you, radiation is a very focal, local treatment. Well, hopefully in the future it'll also be a general treatment where it can go throughout the body and attack cancer cells wherever they may lay.
Well, okay. So explain to me radioimmunotherapy. Is that more
Sure.
they take this pharmaceutical then and say, hey, this is the type of cancer cell that this person has. They apply that treatment and that goes directly to those cells only?
So there's let's just use one example of breast cancer. Okay. So there are certain types of breast cancers that have an overexpression of a protein called HER2. And the drug that's commonly used is called Herceptin. Herceptin is a medication that can be injected or even given subdermally, and it'll go to the cancer cell to treat that. And it's a very effective way of treating cancer, to the point where there are some patients that receive upfront chemotherapy and Herceptin, and their breast cancer, once they have surgery, is totally gone. So, in a similar way, they're now attaching radiation to Herceptin and giving that to patients that have metastatic disease, and those patients dramatically respond well to that treatment. And so, we're hoping to be able to do that for different types of treatments, like for lymphomas, for breast cancer, and potentially prostate cancer. There's a treatment called Pluvicto, which is for metastatic prostate cancer, and patients can receive 6 injections and they're able to have a dramatic response in stage 4 metastatic prostate cancer. So I think that radioimmunotherapy is another way in which we're going to really be able to benefit patients in the future.
Gotcha. It sounds kind of like a Batman and Robin type relationship, right? Where you're attaching that along, and it's like, hey, we used to use just Batman, but now we have Robin that can
Yep.
come in too, and that really shortens the amount of time that treatment is needed. Is that a good
Right,
analogy or no?
exactly.
Okay, good.
I think it's I'm an Avengers guy, not DC, but I think it's a good way to go, and I think I think it's definitely we're getting better and better at what we do, and that's the cool thing about what I get to do for a living is that we're ultimately able to benefit patients, and I think as we're able to develop new technologies and figure out which one is the best for the patient, we work together as a team and deliver the best one for that patient.
Yeah. I mean, I can just tell in the half hour that we've been talking so far that your patients are super important to you. The existing
Yep.
ones, the new ones. Uh, Talk to me about doctors in the community. That's something that's really important to you. Being a part of the community, understanding that doctors are people too, right? They have a
Right.
very specific role in the community, but they're still just human beings, just like anyone else.
So
Talk to me about community
I
for you.
think I think it's important to really keep it real and sort of be low key. We're physicians. Like it's understood that we're this podcast is called Doctors and Dollars, right? So it's understood that we're doing well. Okay, there is no need to flaunt that in any way. I think it's important that physicians sort of keep a kind of a low profile and not necessarily show off their wealth. It's understood that we're really passionate about what we do, and therefore we're well compensated for what we do. But I think it's important to really live a frugal lifestyle and to be able to show that we care about the patients that we treat and the community in which we practice. So I work in a community hospital, and whatever type of opportunity there is to, whether it's a 5K, whether it's the ability to go be involved in a community event that the hospital is involved with, I think it's important that as physicians we show that we are part of the community and that we care about the community in addition to caring for the community. So as a community physician, and really beyond that, I think it's we are stewards and we really carry our own reputation on our shoulders. It's important to try and really live up to that and really work towards working with other first responders like firefighters, policemen, and EMTs to really show that we're part of the team. So as an example, when COVID was really affecting our emergency room, I gave a talk on the role of radiation in emergencies. So kind of to tease out what the role is for what we do, but also just to support the emergency room docs. And we took them a bunch of goodies and made sure that they understood that we appreciate them and all the frontline work that they're doing. And I think it's important to just constantly show that we're community physicians and to show that put the a capital C on that community and really show that and put that up front is really important.
Yeah. That's such a beautiful mindset to have, right? I mean, I've worked with physicians and their families for years from a wealth management space. We now have the Grand Vision Family Office, which is specifically for physicians, just trying to turn high income earning physicians, to your point, a lot of you guys are high income earning, into high net worth physicians. And so there's that.
Right.
We want to be able to help physicians, but I love that you talked about physicians helping physicians. Like doctors got to be in it together, right? In certain
Yep.
circumstances. And I think that's great. Where do you think that mentality came from? Because that's not a mindset that a lot of doctors share. There are the doctors out there that want to drive the Ferrari or the Porsche and live in a multi-million-dollar house to, maybe not show their wealth, but use their wealth. Where you have more of the keep your head down, maintain a nice lifestyle. Where did that mentality come from?
There's a huge rate of physician burnout today. I think that we have to really be aware of that and careful of that. And I think that if we constantly exchange what we do for a living for a paycheck and nothing else, we're going to be in trouble. And that is just unsustainable given all the stresses that we have in medicine. I almost like to pretend like I do what I do for fun, but there's some other thing that's working for me to actually generate income. So the way I think about that is if I am able to maintain a certain amount of lifestyle and quality of life and still splurge on things like I enjoy experiences and travel, but I'm still able to invest a significant portion of my income, that income is working for me. And that generates a certain amount of wealth. Let's say, conservatively like a 5% to 4% rate of, if I invest $1, that gives me back 4 cents at the end of the year, right? So in that way, I think it's important to realize that you don't have to do what you do for the income that you generate to maintain your lifestyle. You can just have a modest lifestyle and then invest and have that investment work for you. Have those investments truly generate your income, your stability, to the point where you don't necessarily need to generate from what you do the income that maintains your lifestyle. You could literally have that other income from your investments supporting your lifestyle if you needed to or wanted to. So that in itself, like the greatest luxury over any material possession, the greatest luxury is that freedom to just walk away if you needed to.
Absolutely, man.
And
That puts
that
a, yeah, that puts
cannot put a
a,
price tag on.
yeah, that puts a smile on my face. That is literally that's like the genesis of Grand Vision Family Office, and everything that my business partner Mike
Right.
and I do is like that's the mentality that we instill in the members of our family office. But honestly, as we're bringing in new families, we're very selective on who joins our family office. We only have twice per year is the application period, and then as we get applications from physician families who want to join, we're very specific about who joins. I mean, they have to have the mentality that you just talked about versus the man. I want to buy everything and show out, and everyone sees that I'm a high income earning physician. To have that modest lifestyle, to understand that investing and creating other forms of income that you could walk away if you wanted to, because you've established yourself financially over here outside of healthcare, I think is super important. And it's a lost art within the healthcare community, I think.
I think that we've kind of drank our own Kool-Aid in believing that, physician, as long as you're a physician, you'll be fine. I think that you need to think of it as there are a lot of people by the time they're my age, by the time they're 50, they're usually well off. Okay. A lot of people are, but few have that sense of purpose, that sense of, I get to do this cool thing with myself every day that benefits other people. That joy is very difficult to find in general. So I think it's important to make sure that you realize the true joy of being a physician is to help those patients. I mean, that's what we all said in our med school interviews, et cetera, right? But when you come back to that, realizing that that is your true joy and your true center, then it makes physician burnout a lot less likely, especially if you're not chasing your tail in a rat race trying to support a high income living, you know? I think it's important to support a high net worth living as opposed to a high income living.
Absolutely. Well said. It really comes down to having two cups, right? Everyone wants to be able to fill their cup. There's the financial cup that being a doctor can fill, right, with the high income. But then there's also the purpose cup. I think that's where burnout happens, is people lose that joy, to your word, that joy or that purpose in what it is that they're doing. They get bogged down with I have to put notes into the EMR, and I have to do this and do this meeting, and it takes away from the actual patient care, which is what actually brings them joy. And so that cup never gets filled. So then they focus on the financial cup of, hey, I'm making $500,000 a year or more. Hey, my financial cup is filled, and they forget about that purpose cup. Does that make sense?
That's fair. Yep,
Okay.
I agree.
Okay. Do you think that's where burnout comes? I mean, burnout really is just doing more of what you don't like to do versus spending your time doing the things that you love doing. And that's how burnout happens. Is that a fair assessment?
It's about time and managing your time and having enough time for yourself and your loved ones. And I think that we realize that time is really our true most valuable asset. I mean, I see a lot of cancer patients, right? They're running out of time. And so I think it's important to realize that time is a huge asset. And even with financial planning, I think it needs to have its limits. Like, I don't really look at the stock market. I don't really, hyper focus on things like that. I mean, it just doesn't matter after a certain level of worth. So I think it's important to realize that it's important to do financial planning. There are certain things you need to do. You need to make sure you have your will, your trusts, your insurance, and then set yourself up with different buckets, your 401k, your IRA, your backdoor Roth IRA, all of those things. But once all of those things are done, there's no time to waste on like where's the S&P 500 today.
Mm-hmm.
It just frankly doesn't matter long term, because that's for your other guy, the amount of money that's working for you to really just sort of take care of.
Yeah.
And when you have it set up in that way, you get to really enjoy the rest of it.
That's awesome. It's so cool to talk to a physician who has a very similar mindset to me. Obviously, I'm outside of healthcare in the wealth management space, and so to be able to hear a physician say a lot of the things that I preach, very very cool to have it said back to me. So thank you for that
I
this morning.
often talk to new grads and new physicians because I think it's important that they kind of get that all straight, because it just really centers them and provides them, what do I do now that I'm making, 5 or 10 times more than I did in residency? Well, nothing. You were happy then, you can continue to be happy, and maybe just have a little bit more, but put that away, put it away and let it work for you.
Bam. Let's put a stamp on that one. That was good. Last question. What do the next 5 years look like for Dr. Rajendran?
Ooh, I don't know. It's a lot of, my oldest is going off to college. My middle one just started high school. My youngest is in 4th grade. So probably a lot of more of the same. But I do think that it's important to always be looking and, reaching for whatever you're able to do. So I now am trying to give back. I do some, I mentor students to try and help them discover medicine and maybe like medicine. I think it's important after a certain time of doing this to realize that it's it's important to give back and important to make sure that you sustain what's there. I think that healthcare, there's a lot of things that could be better in healthcare and the way that it's managed today. I'm trying to help foster that and nurture that within my hospital and within healthcare in general.
That is awesome. ChicagoCancer.org is where people can find you. Where else can people find more about Ramji?
Just, Alexian Brothers and, radiation oncology consultants. I think that really I enjoy the fact that I practice in such a great city and state. And so, yeah, anytime anyone's in Chicago, I'm happy to chat with them.
Awesome. Well, I appreciate you taking some time out of your morning to chat with me today, and I appreciate when our paths will cross at some point in the future.
Same. Thank you, Nate. Appreciate your time.
Take care.